Hi, I'm Jordan Klebanoff. I'm an OBGYN resident at Christiana Hospital, and welcome to this week's episode of Pocket Pearls. Welcome to this week's episode. I'm here with my co-residents. This is Dr. Chelsea Kebido and Dr. Liz Shy, and we're going to talk about massive transfusion protocol. When you're dealing with life-threatening hemorrhage, whether it's on labor and delivery, in the OR, or the postpartum floor, it's important to know what protocols we have in place to deal with these emergencies. So Liz has some questions for us today.
Jordan, what is massive hemorrhage?
Massive hemorrhage is blood loss that requires replacement of your total blood volume within 6 hours.
Chelsea, how do we know when to initiate the massive transfusion protocol?
You should think about activating the massive transfusion protocol when you've given 6 or more units of blood or when you start having microvascular bleeding, otherwise known as DIC.
Can you give me a real life example?
For instance, a couple weeks ago, we had a woman with an accreta or possible percreta who became hypotensive, and we took her urgently to the OR for a stat cesarean section. She'd already lost 1.5 liters of blood, so anesthesia immediately called for 2 units of blood, but we were obviously going to need more. So there is some wiggle room in the situation, but usually if you've had to give 2 units and then you're giving a second 2 units, that's when you're either going to ask the nursing staff or anesthesia to initiate massive transfusion protocol.
It's hard to know exactly. You don't walk into a situation and know you're going to need 6 units right off the bat of blood. But when, like what Dr. Kebido was saying, when you find yourself giving more and more units and the patient's having continued bleeding, so whether it's atony after delivery, whether it's in a C-section and you've extended into the uterine arteries during a GYN case, if you're having continued bleeding to the point where you're approaching needing 6 units of packed cells, you should start thinking about going through this protocol.
So why can't I just keep giving blood?
When you have a patient who is bleeding to the point of having almost bled out their entire blood volume, at that point you're going to need to resuscitate them with more than just packed cells, because as they're bleeding, they're also losing their ability to coagulate and clot. So you need to give back factor and platelets and other things, not just red cells.
So what is a massive transfusion pack?
So when you order the pack, it'll come to the room with 6 units of packed red blood cells, 6 units of thawed plasma, a unit of platelets. It's important to know that cryoprecipitate doesn't actually come with the pack, but can be ordered separately during the case.
So who orders this stuff?
So for us, when these hemorrhages occur in the operating room, usually the anesthesia personnel or the circulating nurses will call the blood bank directly. If you're on labor and delivery or on a postpartum floor, again, you can rely on the nurses to call, but it may come down to you physically calling the blood bank. So that's extension 1819. You need to give them the location, patient information, and a callback number, and tell them specifically how many units of uncrossed blood you need immediately.
So aside from ordering blood, do we need to send any labs?
Yeah, so if you haven't given any blood yet, but you're suspecting that you need to, you'll immediately want to ask for a Titan screen to make sure that one's active and send that as soon as possible. Other labs to consider and that are important are you can do a point of care HemoQ, which will come back immediately in the room, but you can also do a stat CBC and DIC, or instead of the DIC, you could consider doing a TEG, which allows you to do component guided therapy.
So is a hemorrhage in the obstetric setting different than one in the OR?
Yes, it can be different. So when you have obstetric hemorrhage from a process like a chronic abruption or a uterine rupture, where the bleeding is more chronic than acute, you need to think about this ongoing fibrinolytic process that's been happening. So the patient is not only bleeding, losing hemoglobin, but also losing clotting factors. So that's a situation where you would want to consider asking for cryoprecipitate from the blood bank. In acute bleeding, like in the operating room, they're probably still able to coagulate and clot their own blood. So to summarize, I wanted to just spend some time talking about the time it takes to thaw these products and the parameters with which you'll get them back. So for uncrossed blood, it takes about 7 minutes to get. Type-specific blood is 15 minutes. Type and cross blood will take about 30 minutes. Platelets will take 15 minutes. Thawed plasma takes 20 minutes. And cryoprecipitate takes 20 minutes. It's also important to think about the transport time from the blood bank, which can be anywhere from 2 to 4 minutes. Here are these idiots.
All right. Action.
Jordan, what is massive?
So casual.
You should have like a piece of grass in your mouth or something. You don't have to say "good question, Dr. Shy" or any of that stuff.
You can though if you want. Excellent question.
I wasn't that impressed.
Okay. I can't do it.
So you have to replace 5 liters of blood within 6 hours.
Yeah, the typical human blood volume is exactly around 5